Good morning. Thank you for coming out and braving the bad weather today. Before I start, I also want to thank Victor for putting this program together. He's done a great job. Thank you to Eric, who for over 10 years has been frantically adjusting the audio-visual equipment over here for my coming in the last minute with changes in my presentation. And thank you to all the sponsors out there, all the vendors out there for supporting the program. So I was asked to talk about vascular disease and how it relates to diabetes. I just returned last night from San Francisco. There was an international conference there, about 15,000 interventionalists from around the world. We had a discussion on new technologies, outcomes of current technologies, and live case demonstration from around the country, around the world, showing different procedures, surgical and minimally invasive procedures to treat blocked arteries in the heart and in the extremities. This was called the TCT, or Transcatheter Therapies Conference. Diabetes is a disease that afflicts millions of people, and one of the interests that I have as it relates to diabetes is the impact that diabetes has on blocking arteries, not just in the heart. I'm actually an interventional cardiologist, so my primary practice since I started practicing here in 1995 was to help patients with heart attacks and angina and blocked arteries in the heart, but also arteries that get blocked in the brain as a result of diabetes, causing stroke, and in the lower extremities causing we call gangrene as the ultimate or the worst complication due to loss of circulation or peripheral artery disease. So what is peripheral artery disease? It is a disease where the person loses circulation because of plaque, usually cholesterol plaque buildup in the arteries, which blocks circulation. Initially, the first symptoms are usually pain. We call claudication. Claudication is the equivalent of chest pain in a patient who has a blocked artery in the heart. We call angina. The problem with diabetes is diabetes also affects a nerve. One of the attendees was asking me about diabetic neuropathy, in which people lose sensation in the legs. And because of diabetic neuropathy, you can have a completely blocked artery in the leg and not have any pain in your leg. So the symptoms that we look for typically with diseases is absent in patients with diabetes, which often leads to later presentation, later diagnosis, and complications before we can intervene. Patients that do have pain, it limits the ambulation. Without the pain, sometimes it's just weakness. Sometimes it's development of wounds, but ultimately it results in limited mobility. The critical limb ischemia is the end stage of peripheral artery disease, when there's a wound or ulcer that doesn't heal, and then ultimately gangrene. And then the treatment for that, unfortunately, at the last end stages is an amputation. So here's a problem with peripheral artery disease. It's estimated about 12 million people just in the United States have the disease, but unfortunately of those 12 million, only 2.3 million of the patients are diagnosed. So most of the patients are not diagnosed, and even in these small patients who do get the diagnosis of peripheral artery disease, only about 1 million of those, or half of those patients, less than half, actually get a treatment for it. A lot of times it's undertreated, even here in the United States. So it's estimated 8 to 12 million patients have diabetes. That incidence is increasing. And in those patients who have peripheral artery disease, about a third of them will die at 5 years, and half of those patients will die by 10 years, usually complications related to blocked arteries in other areas of the body, such as the heart or the brain, resulting in heart attack and stroke. About a third of the patients, by the time they get to 70 years of age, irregardless of whether or not they have diabetes, will have peripheral artery disease. And about, again, up to 75% of these patients are undiagnosed. In the United States, this is an old number, 150,000 amputations in just the United States every year. And unfortunately, about 40%, or almost half of these patients who get an amputation, never undergo any evaluation for vascular blockages, which may save them from an amputation. The loss of a limb is considered in the United States right now the number 2 cause of severe clinical depression. So here's some facts that came out from the American Diabetes Association with peripheral artery disease and diabetics. About 1 in 3 people with diabetes, so a third of all patients with diabetes, will develop peripheral artery disease in their lifetime. And about every 30 seconds in the world, there's a new diagnosis of diabetes. The patients in 1995, so this is over 15 years ago, in the United States, the cost of Medicare because of patients with peripheral artery disease was $1.5 billion. It's probably double that by now. And 70% of the patients with of the amputations that are performed in the United States are in patients with diabetes. Foot ulcers are very common in patients with diabetes. And the patients that have leg amputation or with peripheral artery disease that eventually end up with amputation, it's 40 times higher if you have diabetes. So right now, the American Diabetes Association recommends everybody who has a diagnosis of diabetes, type 1 or type 2, should undergo a non-invasive study looking to see if they have peripheral artery disease, irregardless of whether or not you have any symptoms. In the United States, it's considered an epidemic right now. About 10.4% of Hispanics age of 20 or older have diabetes, and about 1/3 of all children born in 2000 will develop diabetes in their lifetime. So for the first time in the country's history, the current generation of children have a life expectancy shorter than the parents, and it's because of problems with obesity and diabetes. In 2007, it was estimated in the world about 230 million people had diabetes. Just a couple months ago at the United Nations Summit in 2011, September, that number's gone from 230 to 366 million people worldwide. So this is not just an epidemic here in the United States, but in the world. And unfortunately, here in Los Angeles, this continues to be a rising epidemic. A lot of it is related to poor diet, lack of exercise in children, and the obesity, which leads to type 2 diabetes. When we look at mortality in patients who have abnormal blood sugar, which is diabetes, this blue line here is the mortality over 10 years of follow-up in a person who does not have diabetes. The green line are people who don't have the diagnosis of diabetes but are told that they have impaired glucose tolerance. So their blood sugar may be a little bit high, not as high to make the diagnosis confirmed for diabetes. And then in the dotted yellow line and the red line, those are patients that have clinical evidence by laboratory tests of diabetes, but irregardless of the yellow line, whether they're told that they have diabetes or the red line that they're told that they do have diabetes, you can see that the mortality rate is almost 3 times higher than the patients who do not have diabetes. And as I mentioned, this is related directly to obesity. So this was a study done from 1990 to 2000 in which they looked at the trend of obesity in the United States. The states in white, they didn't have any data from the census. The states in the light blue, such as California, the incidence of obesity was less than 10%. This is, again, in 1990. And the highest incidence of obesity, they rated between 10 to 14% of the population are these states in blue. That's 1990. 2001, 10 years later, no data, zero, they got data in all these states. Less than 10% of the population with diabetes. Remember this previous slide where most of the states had less than 10%. 10 years later, only one state has incidence of obesity, less than 10%. And the highest incidence, they called 10 to 14% in 1990. No longer any of these other states fit in that criteria. They had to go up to 15 to 19% for the dark blue states, such as Nevada, New Mexico, Arizona. The red states, 20 to 24%, up to a quarter of the population now have obesity, and California falls in that. You think of California as one of the healthier states, but actually 20 to 24%, and if you look at Mississippi, over a quarter of the population has obesity there. So if we relate that obesity trend to the diabetes trend from 1990 to 2000, you can see that the trend of diabetes diagnosis correlates directly with the trend of obesity over the last 10 years from 1990 to 2001. And now by the time we get to 2000, over 6% of the population with confirmed diagnosed diabetes, this doesn't even include the undiagnosed diabetes, are all these green states here. Whereas back in 1990, it was almost less than 10% of the states that fit that criteria. So as we go on to looking at peripheral artery disease, the diagnosis, there are some screening programs out there right now. Unfortunately, the screening programs, the people who go to get screened are usually healthy people who are more educationally informed. What we're trying to do is target screening programs in the high-risk patients, the patients in poor neighborhoods, in areas where the diet is not good, where they don't exercise, where they don't have good access to health care. That's where we need to do a lot of this screening, but we also need to educate the public so the public can be aware of when they need to go for appropriate screening. If you go to the doctor, that we're trying to train physicians to ask appropriate questions. In my office, almost all the patients who come in to get seen are coming in because they're looking about chest pain, about congestive heart failure. All of my patients who come in, the first time they come in now, I have my medical assistants take off the shoes and socks. It's amazing how many of these patients will have ulcers or wounds on their feet or poor circulation in their feet that they weren't even aware of. Then we have non-invasive tests, which are basically ultrasound scans looking at the legs to check the circulation. And then once the diagnosis of poor circulation is made, then we do have invasive tests to look at the arteries and to figure out what we can do to improve the circulation. Probably the most common or easiest way of diagnosing peripheral artery disease, which does not require any fancy ultrasound equipment. We just require a blood pressure cuff and a machine to detect an auditory flow of blood in the artery to measure what's called the ankle brachial index. And that basically is if a patient has, excuse me a second, a blood pressure in the arm that we measure, so typically it would be, we think of 120 over 80. The upper number, the 120, should be the same pressure that we measure in the foot or the ankle. And that gives us a ratio we call ankle brachial index, which should be 1 because it should be equal. If a patient's pressure in their foot is less than 90% of the pressure that we measure from the arm, that qualifies as peripheral artery disease. And usually so that would be an ankle brachial index of 0.9 or 90%. If that number goes down to 0.5 or 0.6 or 50% or 60%, those are the patients that are at risk of losing their leg, and also shows an increase in the risk of death or mortality as well. This is a most advanced form of non-invasive screening we have, which is called CT angiography. This on the slide on the left side here shows an invasive study we call an angiogram, where I actually put a catheter into the patient's artery and inject X-ray dye to take X-ray pictures of the artery. This slide on the right side is a CT scan where they inject X-ray dye through a small IV in the arm, in the vein, and they wait until that X-ray dye circulates through the body and gets to the legs, and then they measure or take pictures with CT scanning of the arteries in the legs. And you can see this is the same patient, angiogram in the cath lab in the hospital, a CT scan in an outpatient imaging center. The image quality is very good. So many of these patients now who had to go into a hospital to get a conventional angiogram can now have a CT scan study or less invasive study to get that same information. So what is the treatment for patients with peripheral artery disease? The first and foremost is exercise and diet. Trying to address the issue of obesity, high cholesterol diet, high complex carbohydrate diets, and over excess of calorie intake, and trying to have patients exercise more, not just for the heart, but for the entire body. In patients who have more advanced forms of disease, it's always easier to prevent than to treat. The patients who have advanced disease, medications we have are for treating peripheral artery disease are same medications we use for treating patients with coronary artery disease. Blood pressure medications, medications to lower cholesterol. Probably one of the more popular medications for treating cholesterol you hear now are statin medications. Everyone hears commercials about Lipitor, Crestor, Zocor. Those are well-proven medications to help reduce cholesterol buildup in the arteries and also improve survival in patients with vascular disease. In patients who have advanced disease, there is bypass surgery for the legs, similar to we do bypass surgery in the heart, that are done by vascular surgeons. There are less invasive, we call minimally invasive procedures, we call peripheral interventions, which is what I do in the cath lab for patients with blocked arteries. And then the end stage of the disease where the artery's 100% blocked, there's no opportunities for a minimally invasive revascularization or bypass surgery, and the gangrene has gotten down into the bone, those are the patients where the final treatment option, the only thing left is amputation. So our goal is to try to help patients with early diagnosis so they don't get the disease, our first tier of treatment. Second tier of treatment of patients who have the disease, to open up the arteries and try to help keep them open and try to avoid patients from getting to this very last stage, which is amputation. We're going to look at the difference between surgery, which I think is a very important and valuable treatment option for patients with severe disease, to a growing and expanding treatment for minimally invasive procedures in which we don't have to actually cut the leg open to restore circulation. So we call those endovascular therapies for peripheral artery disease. And the advantage of those less invasive procedures, we do them under local anesthesia and sedation, no general anesthesia. Most patients go home the next day. It's just an overnight stay. And actually, in a lot of centers now, we're doing them in outpatient centers where they can go home the same day in the afternoon. Morbidity and mortality is lower in multiple clinical trials. Earlier intervention in the course of the disease is possible because a lot of times the surgical option, because you're only limited to a few surgeries in your lifetime, they try to postpone any surgical intervention until it's a later stage. And because this procedure is less invasive, it can be reapplied several times or multiple times in a patient's lifetime. So of the different types of devices that we have, or ways of opening up blocked arteries, we can actually go through the plaque with wires and put stents and balloons in to open it up. This is a balloon angioplasty. We have stents, which are metal tubes, slotted tubes that go into the artery to hold the artery open in the site of blockage. We have something called atherectomy, which can actually go in from inside the artery and shave the plaque out and remove it from the artery. We have laser devices that use light energy to vaporize the plaque to clear out channels in the artery. There are special angioplasty balloons that use liquid nitrogen to not only expand an opening in the artery, but to freeze it in hopes of keeping it open. And then there are this is kind of a hybrid type of procedure, which is not true bypass surgery. It does require a surgical cutting, but a smaller incision, and using something we call remote end arterectomy. And then last, we have the latest devices, which are almost like rotor-rooter drills that spin at very high RPM, like 100,000 to 200,000 RPM, to sand plaque and calcium that's deposited in the artery to create a larger channel. So this is balloon angioplasty, which was the original treatment going back decades now, which basically is a small little tube that goes into the artery, and we inflate the balloon to compress the plaque out of the artery. This has been available since 1977, and it's still probably the most popular or common form of intervention that we use minimally invasive to open up blocked arteries. There have been, through the last several decades, iterations of this balloon angioplasty or technologies to try to improve the effectiveness. One is to put small surgical blades on the balloon, so as you inflate the balloon, it's actually creating incisions into the plaque, such as you see here. This is a microscopic enlargement of an actual artery that had a cutting balloon angioplasty called flextome to get a better control of the inflation. As I mentioned, there's a balloon called cryoplasty or cold balloon, which uses liquid nitrogen. So it lowers the temperature in the artery as the balloon's inflated to minus 10 degrees Celsius. And what the idea is that it's supposed to freeze the artery so it's less chance of the artery to re-narrow again, less chance for scar tissue cells to grow inside the artery. And then finally, we hear a lot of talk about stents in the heart to open up blocked arteries in the heart. We also have stents in the legs to open up blocked arteries in the legs. The stents are different from the types of stents that we use in the heart, however. The stents in the heart are metal tubes that are inflated with a balloon, and they're rigid, so they don't bend or move very much. But in the legs, the arteries in your leg, especially in your thigh, when you bend your knee, you flex your hip, the artery in your leg is constantly stretching, compressing, and it's actually torquing. So we cannot have a stent that's a solid, rigid metal tube. We actually use stents that are made out of something called nickel chromium or nitinol, which is a metal developed by the military that has memory in it. So it's almost like a spring type of material that can be bent, twisted, and still stays in the artery to act like an internal scaffold to hold the artery open. And then we also have stents made out of nitinol that have Gore-Tex covering on it that has, we call covered stents. So those of you who have Teflon frying pans at home or waterproof Gore-Tex jackets, W. Al Gore developed something called PTFE. PTFE is Teflon, which they use in frying pans to prevent sticking. And it's also the same material that's in Gore-Tex that makes waterproof jackets waterproof. It doesn't allow any fluid to permeate through it. So they actually have Gore-Tex or Teflon covered stents into arteries that can be put in to help block off areas where there are aneurysms or blood clots to trap it inside the space between the stent and the arterial wall to help keep arteries open. And then probably the most exciting type of devices that we've been using here at Good Samaritan Hospital a lot are the atherectomy devices, the devices that don't just compress the plaque like a balloon or a stent, but actually remove the plaque out of the artery. And those, we'll talk about the 4 different types of devices: the orbital atherectomy, laser, directional atherectomy, and rotational atherectomy. The rotablator atherectomy was the first atherectomy device available for opening up blocked arteries, and it's an elliptical burr. This is magnified hundreds of times. And on the top you can see how it looks kind of rough. These are small diamond particles on the front of this, and it goes over a wire. We pass a wire through the blockage. This device would spin between 150,000 to 200,000 RPM, like a true roto-rooter device. This is showing what an artery looks like after balloon angioplasty. So all this stuff in the middle of the artery is plaque. The balloon tore and compressed the plaque open, but you can see the plaque doesn't leave the artery. We just have a lot of small spaces in between the plaque that the blood can flow through better. This is after the rotablator atherectomy, where the device actually sands down the plaque and shaves into small particles. These are the particles that of the plaque or the cholesterol that were sanded down. This is, you know, the dust that you get when you sand wood. This is what that is inside the blood. These small round things are red blood cells. So the sand particles get shaved down, they get into the bloodstream, the kidneys filter it out of the blood, and it passes out in the urine. And so this device is available for use in both the heart and in the legs. But because of all this sanding, you can imagine if you have a teaspoon of sand, you pour it in your toilet, and you flush the toilet, it'll wash out. If you get a bucket of sand, even though it's the same small particles, you dump a whole bucket of sand in your toilet and try to flush it, it's going to clog up your toilet. So we have to be careful when we use this device that we're not sanding down too much material, because it will plug up the small vessels that are downstream and cause complications. There's a newer iteration of this device called the orbital atherectomy, which again was designed for the legs. We're actually in a clinical trial in the United States here using this device to see how it performs in the heart now. The first trial in India using this in the heart worked out very well. And so far, we've got about, this was one of the meetings we had up in San Francisco. We're approaching 200 patients in the United States with excellent outcomes on this device if the patients have calcium in the artery. And this is the same concept. There's small diamond particles. This is a magnified view of the diamond particles embedded on the device. And the device spins inside the artery to sand down the plaque. And at a lower RPM, such as 80,000 RPM, the device sands, creating a small lumen diameter. The higher RPM, if we go from 80,000 to 120,000, this they call medium here, or high RPM to 180,000, it wobbles more and creates a larger diameter or lumen inside the artery. This device is particularly useful for arteries that have calcium deposits within the fatty cholesterol plaque inside the artery. And the other technological aspect of this device is because the diamond particles preferentially send calcium, if it's a normal part of the artery that's soft and elastic, the device doesn't perform well on it. So that's a safety issue that decreases the chance of a perforation. And again, the particles that this device generates are much smaller than the size of a red blood cell, allowing the particles to wash through the blood vessel to the circulation and get extracted through the kidneys and passed out in the urine. The other atherectomy device that we have here is called the excimer laser. It uses light energy, and we again pass a wire through the plaque. This device uses a cold type of laser light that when it hits the plaque, it vaporizes it and turns it into a gas. It actually creates these bubbles inside the blood vessels. It vaporizes through and creates a nice channel through the artery. Again, this device is pretty small, so the actual lumen, or the size of the artery that it can enlarge the opening to, is limited. But it does have a nice benefit in that if there's blood clot as well as cholesterol plaque in the artery, this device can actually dissolve or vaporize the blood clots in the artery as well as the cholesterol plaque. This is a device that we've been using here since about 2004 called the Silverhawk atherectomy. This is one of the first YouTube videos that we created for patient education with Andrew Dillard. I don't know if Andrew is here. He's been very instrumental with patient education, physician education programs here. This device actually goes in, shaves out the cholesterol plaque, similar to a carpenter planing down a door. But in this instance, because these particles are so large, we actually have to collect it inside the catheter and remove it from the body. But this device has a small blade on the back end that as we advance it, the plaque hits this blade, it cuts the plaque and pushes it in to a reservoir at the tip of the catheter we call a nose cone here. And this device, as opposed to all the other devices, in the early clinical trials showed that it performed as well in diabetics as in non-diabetics. Balloon angioplasty, stents, all these other devices in patients with diabetes, unfortunately, had a higher recurrence rate after the procedure if a patient had diabetes. Whereas this device here seemed to have as good a patency rate after intervention as with this device, with the Silverhawk, as with the non-diabetic patients. So this is showing the device actually working in animation. The wire goes through the plaque. We rotate the device so that the blade comes up. We engage the artery, and as you push it, it's like a carpenter's plane, is shaving the plaque and storing it in the nose cone. You can see the yellow stuff collecting in the tip of the nose cone here. After we pass through the plaque, we close it so nothing leaks out. Pull it back. We rotate the device so we can cut plaque that's built up on the other side of the arterial wall and do the same thing. And this is all done from inside the artery using X-ray imaging, we call fluoroscopy, under local anesthesia. Now, some of you may say, well, what happens if some of that plaque breaks loose and doesn't get captured in the device? While we're doing this, the wire that we use has a filter basket, like a net at the end of it, and blood's flowing down. So we actually use this as a protection, we call distal protection, in case any particles come loose. This is a picture of the plaque that we've removed out of a patient with artery. This is the filter wire, and you can see there are a few pieces that got caught in the basket here to prevent it. We call it embolic complication. There are other atherectomy devices that have been approved since then. There's something called a ClearPath, which has, small blades that cut the plaque, but it's connected to a vacuum bottle at the back end, so it sucks stuff into a chamber on the back end as it's cutting. And then in patients who have blood clots in the artery, we have something called the angiojet thrombectomy, which is designed not to cut plaque, but just to suck loose debris such as blood clot out of the artery. We use this in patients who have blocked arteries with blood clots. We use this in arteries in the heart when patients come in with heart attacks, because a lot of times it's a blood clot in the artery on top of a plaque that causes a heart attack. We use this in legs, and we also use this in patients in the veins on the other types of blood vessels that return blood to the heart for clots in the veins in the legs called DVT. More recently, we've been using this in patients with pulmonary embolism, where that blood clot in the leg migrates into the lung, causing a life-threatening complication. This is the reason why we use this device if there's blood clot in the artery before we put a stent in, because if there's blood clot, the stent expands, we open up the cholesterol plaque, but the blood clot can cheese grate through the opening in this stent and migrate downstream. So before, if we have any suspicion of any clot in the artery that we want to put a stent in or do balloon angioplasty, we'll pre-treat it with that angiojet thrombectomy device. So this is just looking at statistically patients who have peripheral artery disease. About 20 to 50% of the patients are asymptomatic. They have no symptoms at all. Only about half the patients will have will have atypical symptoms. They think that they have leg cramps or spasms in the leg, not true PAD type symptoms. Only about 10 to a third of the patients have true claudication. And then in patients that present late, only about 1 to 2%, but these are the patients that eventually go on usually to amputation, have critical limb ischemia. After 5 years, these patients who were asymptomatic or had minimal symptoms, about 2/3 of them will remain stable, about 10 to 25% will get worse, and then another smaller percent of these patients will continue to fall into the category of the critical limb ischemia. And when we talk about patients, since we're talking about vascular disease, stroke, heart attack, and PAD, the time from when the artery blocks to when you have a bad outcome is most critical in patients with stroke. So I'm glad to hear there are commercials on the radio and TV now telling patients if you are at home, all of a sudden you lose control on one side of your body, or you have problems, all of a sudden you can't speak. Those are the very first signs of a stroke. And when that happens, you don't stay home or wait for someone to call up. You don't call your neighbor or family to get help. You call 911. And the reason is because from the time that artery closes to the time when you start having brain tissue death or injury is 4 to 8 minutes. It's critical that you get in as soon as possible. You don't wait for somebody to come and help you. If the artery closes in the heart, that's what causes a heart attack. You have 17 to 20 minutes before there's irreversible heart muscle damage. And in the legs, you have 5 to 6 hours. So the legs are more tolerable, but I can't tell you how many patients will come in with a cold leg that started 2 to 3 days before they came in. So very important that you get patients or your family members educated that they need to call up as soon as possible when they come in with a symptom of a stroke, heart attack, or leg ischemia. I'm just going to jump ahead to a couple of graphic slides here just to show you some actual patients that we've had. This is a patient who had an ulcer on his foot for 1 year and didn't seek any medical attention. They kept trying to clean this thing. No one made the diagnosis of peripheral artery disease. They kept thinking that this was an injury from a burn or a blister that wasn't healing. He finally came in. One of the arteries in the lower leg was 100% blocked. There's 2 arteries that were open, but the third artery in the lower leg goes to the bottom of the foot, is absent here. And we used some devices to get through the blockage. We used that sanding device, the orbital atherectomy. This is the artery that was absent before. And then once we got that open into the foot, the arteries were still blocked. So we used that device all the way into the bottom of the foot. This was 4 weeks after the procedure, and this is 2 months afterwards. This went on to completely heal. He had the same problem on the other foot. This is another patient came in with a heart attack, but had had black toes for 3 months. And after we treated the heart attack, opened up the artery in the heart, we then had to bring this patient in. This is the artery up in her groin. This artery is 100% blocked from the groin all the way down to her foot. This is a wire that we're using to try to get through that blockage. And this is that Silverhawk, that atherectomy device that we used to shave that plaque that was blocking the artery. This is the artery now after the Silverhawk. We got it open into the leg. This is all the plaque that we took out of there. She ended up having her toes amputated, but she did not have her leg amputated after we got that opened up. This is a physician who came to me with 1 year of ulcers on his feet that he was self-treating. He was a dermatologist. He kept thinking that this was a dermatitis. He was treating with steroid creams. And finally, a friend of his, who was a physician, sent him to me. We did an angiogram. The arteries in his legs were completely blocked again. We used a device to get the plaque opened up. Like this was immediately after the procedure. We removed all the creams and things that he had on his feet. You can see these ulcers on all his toes here. This was 7 months later now, almost completely healed. And we actually ended up having to do the same thing on the other foot. Once we treat these patients, one of the problems is the disease tends to recur and blockages recur again. And that's why it's important, even after we open up the blocked artery, we have these patients followed by a wound care specialist very closely. This was a patient that came to us with a heel ulcer. And this is, at the time we opened it up, all the plaque that we removed from the blocked artery. But we see this patient every 3 to 6 months. This is now 3 years later. You can see this thing completely healed up. They wanted to do an amputation on her leg when she first came in. So we're involved with several research studies. One is a study where that plaque that you see that we removed, we sent this to a human genome lab where they have the entire human DNA mapped out. And they're trying to figure out gene-directed therapy, a pill that you can take to help prevent or to treat atherosclerosis. And one of the things that we found from that study is the genes that are expressed in the arteries and the legs in diabetics versus non-diabetics is different. So there's going to be different medication therapies, but in the future, I think that's what's going to be the future treatment of atherosclerosis is hopefully not all these interventions and surgeries and procedures, but a medication to help prevent the plaque buildup. And currently, we're involved in a study here at Good Samaritan Hospital where we're one of only 15 hospitals in the entire United States with a special balloon angioplasty. It has a medication coating on it to help prevent that artery from re-narrowing again. It's called Levant 2. The initial study in Europe last year looked very favorable. It reduced the re-narrowing or restenosis rate by over 50%, and we're hoping in the Levant 2 that we'll have the same results here. So this is life is not always fair, but hang in there. This is a video. People kayaking, and the poor guy gets landed on. But he's not going to let that ruin his day. He gets back up, and he starts paddling frantically to the shore. So our message to patients out there is prevention is much easier than treating the disease and its complications once it occurs. But in patients who have the disease, even when it's diagnosed late, the message is do not accept what in a lot of places is a community standard just to amputate the leg. We want to give hope to patients who are in a desperate situation. And before anyone cuts off that limb, you have to have yourself or your family member or your friends, they have to know that everything was done possible to save the limb. We've just looked at our data here from 2004 to 2007. We're actually publishing a paper. Patients with critical limb ischemia, with wounds, gangrene, which in a lot of places the treatment choice would be amputation, we had an 84% limb salvage rate at 1 year. And so between the surgeons that we have here and the interventionalists, there is hope. You know, we would prefer to prevent the obesity, prevent the diabetes, but when the complications are already present, that doesn't mean that the treatment of amputation, it has to be the first or ultimate choice. Thank you for your attention.